today's date? 4/9? I tried to wear doctor clothes today. I got tired of wearing jeans. I never thought I'd say that. All right. I'm going to do some follow-up on previous topics. I'm going to answer a couple of good questions that came through that I might not have very good answers for. And I'm going to encourage anybody who watches these videos or knows anybody that has a question to submit them through Liz so I can be ready for them tomorrow. The first thing I want to address is a question, and I'm going to get to yours second, is I briefly talked about different antibodies yesterday, and I mentioned IgA antibodies guarding the GI tract. And somebody asked a very logical question, which is, if I'm taking an antacid, would that be a problem in regards to whether your IgAs can protect you or how that affects the virus, et cetera, et cetera? And the answer is, I have no clue. And I'm not sure anybody does either. And so does pH of your intestinal tract affect this? And it might, but I'm not an expert in that. I'm not sure. Everybody's been so focused on the respiratory symptoms here that because the GI tract, even in the case of severe diarrhea or colitis, is probably not going to kill people at the same rate that acute respiratory distress syndrome will. I don't think anybody's really focused on that clinically. I'm going to grab my point. But I do want to follow up on something about the GI system, which I find very interesting. And so I'm going to propose a hypothesis today, which basically means, as a scientist and a clinician, I have a suspicion that something's happening, but I have no proof. It's based on what I've read about everything to date, and it's based on my knowledge of the human body. But it'd be a really interesting, in my opinion, thing to test at some point. So if you guys remember that the receptor for COVID-19 is highly present in our nasopharyngeal, upper airway, and lower airway epithelium. And it's also highly prevalent in our entire GI tract. It's the angiotensin receptor, ARE2, I think is what it's called, or ACE2, I can't remember exactly what the term is. The bottom line is, this virus has a very high affinity for that receptor in our respiratory tract and our GI tract. We're all focusing on upper respiratory and lower respiratory symptoms of cough, nasopharyngeal symptoms, sinus headaches, I think are part of it, sore throats. But diarrhea is a really common symptom, and I think it's underappreciated. And my hypothesis is based on some observations and then reading some of the Chinese data. I suspect that if you are inoculated primarily through your respiratory tract, that you inhale this virus, that your primary first symptoms are likely to be respiratory, because that's where the virus is dividing immediately, right? I mean, that would be my guess. You will seed your GI tract because every time you cough, you get sputum into your mouth and then you swallow it. So it's a natural entryway into your GI tract. It happens. What's kind of gross on the other end is I suspect that if you actually touch a contaminated surface and then touch your lip or something and get it into your GI tract first, then one of your presenting symptoms may, this is my hypothesis, may be GI. And there are people who definitely have diarrhea as their presenting symptoms. Now, nobody likes talking about diarrhea, right? To your boss, to your family, to your coworkers, to your friends. That's not a very pleasant topic, but it's a common symptom. What's really gross about this, but I think a realistic problem, is that whenever you go to the bathroom with diarrhea and you flush your toilet, you aerosolize all that stuff. And there's, I'm sure, videos that would gross you out to no end point of how this happens. And so if you micro-aerosolize, this is purely hypothetical on my point, infected stool water, and you breathe a microscopic amount of that in, well, guess what? your secondary symptoms are going to be respiratory. Because your primary source was your GI tract, and then you fed yourself. So again, that's just purely speculation, but it dawned on me when I was trying to look it up, because even though it's not on the state questions, I was asking the state this morning, I go, I'm sure you're hearing a lot of diarrhea, and they're, yes, we definitely are. And it's definitely part of the symptoms published all around the world. So, interesting tidbit. Whether antacids are good or bad, I don't know. All right. The second question came from reading articles that say, perhaps a lot of people who have had COVID-19 a few months ago and didn't know it was COVID-19. Is there any truth to this? This particular person may have had a horrible flu-like illness in December, thought it was food poisoning, blah, 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 worst flu of their life, went to the doctor but tested negative for the flu. Maybe it was a false negative flu test. Could it have been COVID-19? I guess. That's my scientist answers. I don't know. But the interesting timeline here is that, you know, we have a couple speculations. You know, the world is thinking that the first patient who ate the bat soup or whatever they ate in Wuhan province occurred sometime in mid-November, right? And then it spread in the community, and then by December, January, February, through March. Let's go ahead and put April on there because I'm going to cut that out in a minute. China's curve, according to their reported mortality data, kind of looked like this. Right? So that's their curve, in essence. And so that's all based on the first patient being here. I forget what it was. It was right before Thanksgiving. You guys remember that the biggest problem for our world, I think, was Chinese New Year. No fault of the Chinese government or people that celebrate the Chinese New Year, but it's a very common tradition, kind of like our spring break or Christmas here, for everybody to go home, spend time with their family, and then when it's done, they go back to wherever they live. Whether it's they go back to Italy, which has a lot of Chinese workers, or they go back to their colleges where they're studying in Seattle or New York or LA, or their labs that they're working in, or whatever their jobs are here in our country and every other country around the world. Because we have a global society. We have people from every country in our country and vice versa. Bless you. So, when was our incident patient? I don't know the exact dates here, but you know, remember the Seattle problem became an issue in January-ish, right? And then we started paying attention to the local news. Is that right? You guys remember? Help me out here. Somewhere around that time, right? And then our curve started going like this, right? To where we are now. So, getting back to the question, I was sick in December with the flu-like symptoms or viral symptoms. Could this have been COVID-19? Theoretically, yes. And theoretically, there could have been some micro-spread in our country based on where it was in China, because it was probably, you know, here. But again, probability says unlikely. Because what was going on in our country in December and January was mostly flu. And even all of us healthcare workers who likely got the flu vaccine, I haven't looked at the data, but I'm not, you know, the flu vaccine didn't cover everybody this year. Or you still got sick, maybe not as symptomatic, which is the nature of some vaccines. Okay? It protected you from horrible symptoms, but you still felt pretty lousy. That could definitely happen. And I don't know what the sensitivity or the false negative rate is of the current flu test, but my suspicion is it's pretty comparable to the COVID-19 test because you have to do those nasopharyngeal swabs. And for the same reasons I got really worried about the nasopharyngeal swabs for COVID-19 missing people, I think it likely applies to the flu, but I don't know. I'm sure somebody could Google false negative rate for United States current flu season and have an answer. My guess is there's certainly scientists that have that answer already. So the probability of a December illness, viral illness, I'm going to call these viral symptoms because the flu and COVID are not that dissimilar. By probability, it's unlikely. Scientific possibility, maybe. But again, you also might win the lottery. For people, I have patients who said, gosh, when I was doing telehealth clinic yesterday, I was pretty sick at the beginning of March. I go, well, did you get tested for the flu? No, because they told me it was probably the flu. And I said, well, that was a pretty good guess at the time because here at the beginning of March, I don't know if you remember what you guys were thinking. I certainly would have been very worried about this. It was my first realization in mid-March. I didn't give it a second thought at the beginning of March because I had not spent any effort looking into the probability of this becoming as big of a crisis as it was. And that's my own fault. But I was an early adapter in mid-March, so early adapter, because I think there's still people that haven't adapted yet. Nonetheless, the patient that tells me they had diarrhea, headache, cough, and high fevers for 5 to 10 days in early March, but didn't get tested for the flu, could they have had COVID-19? Yes, for the same logic that I told you already. However, these are people who work in hospital settings, who live in our area. Could that have been COVID-19? Yes, but again, the widespread crisis hadn't really hit. I mean, if it was somebody today with those symptoms, where we're here, I'm going to say everything is COVID-19 until proven otherwise, right? Because we're in a different situation, because now it's not just every once in a while you'll run into a rare case of somebody with it. Now, we're just assuming everybody who's sick has it. And that's because we're deep into the curve now. And so the density of sick patients has increased substantially. And as each day goes by, the density of sick patients who likely have COVID, that means the next day there's going to be more likely those people. So again, it's all based on the density and the likelihood at the current date. So that's my simple answer for the question, which is an intriguing question, completely unscientific in my answer, but just speculatory. And I think it's all based on statistics. And so when I say unlikely, more likely, for sure, probably for sure, I think it's all based on the density of the infections around us. As an aside, and I don't know whether this is conspiracy or fact because I have not looked into it yet, there are people who research stool samples for whatever reason. And there are some reports that stool samples prior to this November date may have actually had this virus in it, which is somewhat intriguing when you consider that maybe this wasn't November, maybe it was weeks to months before that. Again, I'm not going to feed into any conspiracies. I just think, again, when we can recognize it and diagnose it, just like in patient symptoms, I think we need to realize that it's probably been there a little bit before then we were smart enough to find it, both at the macro and the micro scale. So, that's all I got for today, guys. You have a question?
Yesterday we talked about the O versus A.
Oh, shoot. Yes, I was supposed to look into that, wasn't I? I didn't write it down. O versus A, blood typing, and coronavirus risks. Liz, will you take note of that, and that'll be the first topic tomorrow?
Sorry, Nora. No, that's okay.
Did you find anything you want to share?
Just that it's really not scientifically proven yet. it's up in the air. I mean, if you look at the studies that were done in China initially,
Yep.
more A's had an O's. However, if you look at the blood type of people there, there's more A's there than, that, so there's a lot of different factors that could skew that.
It's
So,
intriguing, and so this is what we call observational data, which is you report what you see. I mean, it's what we do as human beings every day, right? Well, we think you're sitting there because I can see you. That's pretty good scientific evidence, right? So we can count how many people with different blood types have had it, whether there's a relative risk for a blood type for getting the virus versus severity, morbidity, or mortality from the virus, I think is unknown. But maybe there are correlations, and I'll look into that as best as I can in the next 24 hours. The other thing I've seen reported along those same lines is the male-female severity of illness, because males are supposedly dying at a higher rate than females. Obviously, there's a link to comorbidities that we all have just trusted that, and I think it's based on more than just correlation. I think there's likely a causality to that, which is the difference between observation and science. Observation is one thing, and you can make predictions based on observation, but causality means you prove this caused this. And so male or O blood type caused you to die at a higher rate than female with AB blood type. That's the difference between observation and correlation and causation. And so I'll look in and see what we got. But I think those observational things are really intriguing. At some point, though, you sit around and you worry about all your different risk factors. And really, from an individual standpoint, what you need to worry about is what your risk factor is. And the best thing you can be is a healthy young person. And so what I tell everybody is go walk and exercise for 10 to 20 minutes every day. And if you're a smoker, quit smoking. So, you can't control that you have the blood type you have. You can't control your gender. So, can't worry too much about that. It's just interesting at this point. You can control your pulmonary reserve by exercising more and stopping smoking. So that's I focus on things that we can have a positive outcome from. But I do want to look into that and see if there's others too. Good question. All right. Yes?
Yeah, until I said like 2 weeks ago, it was like all over the place that you weren't supposed to take ibuprofen because somehow it made you a lot more likely to die from COVID.
Yeah, I don't know where that came from. I put zero effort into researching it. I think you asked us at a meeting a couple weeks ago too. And I have no idea where that came from, and I have no idea whether there's any scientific data to back it up, or if it's just a possible propaganda, not intentional. People just came up with this idea and got worried about it. Maybe there's actually correlation. Again, that's in the same topic of correlation versus causality. And I'll try to look into that as well. As far as I'm concerned, if I get a fever, I'm going to start with Tylenol. So this is, again, a positive solution. If you can use Tylenol for your fevers, use Tylenol. Because that rumor or whatever it may be, or fact, if it may be that, doesn't apply to Tylenol as far as I know. If you really have a really high fever and Tylenol's not touching it, and you're getting sick and you need to get your fever down, is ibuprofen okay? Probably. As your clinician, I would say yeah. But am I being irresponsible because I don't know the data? Well, I'm having a hard time keeping up with all the data. So I'm going based on my clinical intuition. And that's the problem with the internet. Sometimes it propagates stuff that's not science, and it gets in the heads of our healthcare providers.
This was a couple of pulmonologists that had said this.
There's an
And
article from-
maybe they've researched it and it's true. I don't know. I can tell you Dr. Latin is standing here in front of you, doesn't know the answer to that. And so my clinical impression is it's not likely, number needed to treat wise, to be a big impact on an individual basis. So even if there is some science, number needed to treat is a concept that says, or number needed to harm, how many people have to take ibuprofen before it affects one person negatively? And let's say that's 100. Well, you have pretty good odds that you can take ibuprofen and you're not going to die from coronavirus. Especially if you're young, healthy, and have good lungs otherwise, right? You're gonna feel better if you got that horrible fever and headache. So, you know, every problem you have to distill down and say, you know, does this really apply on a micro scale to me? It might, but again, you might win the lottery if you buy a ticket tonight. So, there you go. Let's wrap it up for the day. Thanks, guys. And you guys, I truly appreciate you guys coming every day. And keeping me reading. And I apologize for missing you.
No, no problem. A lot of these subjects just come up in conversation, and so I want to pick your brain.
Yeah, you